Well, good morning, everyone. Welcome to Grand Rounds. And our speaker today is Dr. Ashton Clayborn, and she'll be speaking on teaming. And as you know, teaming is one of the focus areas under the Clinical Learning Environment Review, known as CLEAR. And our program is underwritten by an educational grant through OSU Medical Center, Graduate Medical Education, and a disclosure statement has been signed and is on file in our GME office. Dr. Clayborn is currently an Associate Program Director at Choctaw Nation Family Medicine Residency. Originally from the rural town of Purim, Oklahoma, she completed her undergraduate studies at Northeastern State University and graduated from OSU, College of Osteopathic Medicine, through a dual DO and MS program. Her residency training with Choctaw Nation Family Medicine Residency has provided her with the full scope family medicine experience in a rural setting that she hoped to remain in. Dr. Clayborn's background and research also has sparked her interest in academic medicine. She now enjoys the opportunity to provide clinical care, continue her scholarly activity, and teach future generations of rural family physicians in her current leadership position. She and her husband have 4 young children and spend most of their time attending various kids' activities, raising cattle, and occasionally playing on the water at Lake Eufaula. Please join me in welcoming Dr. Clayborn.
Thank you, Dr. Alexopoulos. If you'll give me just a moment, I'll get my screen shared and we will get the show on the road. Okay, can you see my screen before we get started? Okay, thank you. All right, and thank you for the wonderful introduction. When I was asked to speak on this topic, I, being the CLEAR champion here at Choctaw Nation, thought teaming is one of the focus areas that we could use some more information, and there are just so many interpretations of what teaming can mean, and I wanted to study it a little more myself and maybe bring to light some of the issues we have with teaming and the current interpretation and definition of team, and work on that a little bit, because most of our background is medical and not so much leadership. So hopefully I will present some concepts today that are helpful, and I tried to make it as relevant as possible. You know, I had at one point putting this together, thought maybe inborn errors of metabolism would be more helpful and interesting, but I tried to adapt the presentation such that it'll provide some thoughts and skills that may be useful as you're going through your day-to-day work in medicine, but also as you're recruiting new members of residency programs and creating teams within the hospital. So we'll get started here. I have no personal conflicts of interest to disclose. Our objectives today are to define teaming. It seems simple. I think we all have a definition in our head, but I'd like to compare and contrast that with the traditional definition of team, and we'll get to that shortly. I'd like for you to understand the value of team diversity. Again, seems like a cultural thing specifically, but that's not quite where we're headed today. And then to identify and describe some characteristics of a physician leader and give you some skills using a conflict resolution strategy that may be helpful as you see yourself becoming a physician leader, or if you already are, maybe just a new way of thinking about things. So since I had to have a picture of a team, of course, I chose my own children. Why not? We played in the state tournament this weekend at Oklahoma City. It was more crowded than it should have been, I'm sad to admit. There were masks other than this picture, but still had a good time. They finished state runner-up and 3rd place in the state. So this is what most people think of when we think of a team. It's a team of individuals that share a similar skill set, and while some may have certain specialties, they share a similar skill set and are working toward a common goal. And they practice together, and they maybe have plays that they run, and those things are practiced. That's different than a pickup basketball game, where you're still maybe working toward a common goal, and you may have very skilled people, but the practice and the rehearsal of that is not quite the same. And so when we think about teaming, that actually is more like the definition we'll talk about today, where we are working for a common goal, which in many cases is patient care, but sometimes is an academic project or research, or simply just accomplishing a teamwork task that requires a group effort. And I think many physicians are type A by nature. I was. And so it is in our nature to sometimes want to just take the lead, avoid group work, and do it ourselves. So I would like to see us maybe shift away from that mindset today. It definitely takes a shift for me in my mind to get away from that. So the definition of teaming here today is actually one where we are going to talk about putting together pieces on the fly. These groups, sometimes I think about our teaming groups here where we have interdisciplinary individuals who come together and maybe take care of our hepatitis C patients, or our integrated behavioral health specialists and how they work with us in our clinic when we have a patient in crisis, or even sometimes not in crisis, but they need that service. And so I think about all those pieces and how, yes, we talk about things and we have formal meetings, but often these teams come together on the fly and we don't always have that rehearsed game that we're practicing. And so the skills I'll present today and the thoughts and ideas I'll present relate more to that situation where a team comes together on the fly. We still have that common goal, but it's not always a rehearsed situation. So first thing I'd like to do is actually talk about diversity and how that may help a team. So you saw my children in the picture there. A lot of those team members look the same. They're in the same grades. They share a lot of the same skills, and they're just trying to develop at this point. In medicine, we're beyond that now. Most of you are, I'm sure, in residency, depending on what level. I'm sure we may have some attendings in who are present today. And so we're kind of beyond that, like, okay, everyone's just trying to develop phase, and we are now at the point where we are professionals, and these teams and the goals that we're trying to accomplish are far beyond, hey, let's just make everybody a little better. So what can we do to improve upon that? So chances are, as soon as you hear the word diversity, your brain just immediately conjures up some preconceptions. By this point, everyone likely has had some form of diversity training, and you probably have varying thoughts about the necessity and the efficacy, or even the politics of these initiatives. And so I'd like to actually stay away from that today. And I'll start by immediately saying that we're not going to present an ideologic argument. This is not a typical, okay, we all need diversity, it's about culture, but actually I'd like to go beyond that and say that we're not going to talk about why it's the morally right thing to do today, but I'd like to outline the evidence and build a case for why diversity is the smart thing to do. And much of this is derived from Scott Page's book, The Diversity Bonus. I also adapted some of this from a curriculum that we use, a cultural curriculum from a surgical residency program in Michigan. But basically, we're going to avoid the it's morally right, it's the right thing to do, and talk about how diversity from the medical and teaming standpoint can make us more successful. So it's not ideologic, and hopefully I can provide you some evidence. This certainly changed my way of thinking, even through our interview season this year. So when defining diversity, it's definitely more than identity. Identity is just one aspect. I also would like to talk about cognitive diversity, and those are the differences in how we interpret, reason, and solve complex issues. Now, to be sure that there are ways that identity parameters shape your cognitive diversity and skill set diversity, we need to think about it in that way. The ability to speak another language is an obvious example, but we want to avoid the assumptions that just because you look a certain way, that you think a certain way. And I think that's very common for many of us, unfortunately, whether we like to admit it or not. So to illustrate this, let's walk through a few examples of how diversity can produce a bonus when it comes to teaming and working together. Here's an example that does appear in Dr. Page's book, where we have 3 people with varying amounts of cognitive tools. And those tools are represented here by A through G. Conventional wisdom says that the best teams are made of the best individuals. How often do we feel that way in medicine? And even when we're putting together groups outside of our workplace, it's in our nature, and we are biased toward creating teams that are similar to ourselves. You can't help it when you have certain skills, and those maybe are your strongest skills. You see them as being beneficial. That's normal. That's okay. That's a good thing. But this approach made it clear to me in a very factual way, and doctors often need that, that we actually need to look outside the box and think in such a way that not everyone needs to be like me to be successful. Seems obvious maybe, but the math here really made it clear for me. So if the traditional way of thinking is you would choose the 2 individuals who have the highest skill sets. So in this case, that would be purple and red. And so I know the colors are showing up a little differently here, but that would be the person on the left and the person in the middle. Makes sense. However, if you look at the actual skills in question, purple and red, or the 2 on the left, the far left side, actually overlap quite a great deal. So the number of unique skills in this team is 6. But if you look to the other side, and those were yellow and red, but now they're pink and light purple, in contrast, they actually have empirically fewer skills, but they end up with a team with broader capabilities because there's less overlap in those skills. So that seems like a very simple concept, but it was actually kind of enlightening for me when I thought about it that way with numbers. I'm a very numbers, evidence-based visual person. And so putting it together this way really made me think about, again, I first came across this during interview season, and it made me think about the team that we were putting together. We often talk about fit here at our residency program, and that's still so important. But fit isn't always who looks and thinks the most like you or who has those textbook characteristics that you think should be on your team. It actually may be a diverse skill set that creates the most diverse team. And so this does parallel to medicine. We all know that it's highly competitive, no matter which phase of training you're in. And finding the people with those highest test scores, most publications, most grant funding seems to be the obvious answer. But this model helps to show that in an organizational context that's highly dependent on teams, that most may not equal as much as different. So here's another example of how diversity can work and how it can sometimes fail. And that's not to say that all tasks require diverse teams. So in his book, Page talks about the breakdown in the kinds of tasks that workers face, because we know there are times in medicine we just need the expert or the team of experts. And so this model kind of demonstrates that, and the times when it may be right or more appropriate to have those experts versus a diverse team. And so here's another way of thinking about it. Those manual tasks are those that are performed with our hands and our bodies. And routine tasks are those that could be handled by a program or machine, whereas non-routine vary and require adaptation. And cognitive tasks are those that require our thoughts and input. So there's some overlap between those, and that's the grid that we have here. In most of these tasks, diversity does not create a bonus. So if we take a manual routine task that basically is hands-on, machine could nearly do it, the best team would consist of the fastest and strongest wood chippers. So there's our pile of wood chips there. And replacing a top wood chopper with a weaker individual who happens to know electrical engineering would increase cognitive diversity, but your team performance is still going to suffer. However, if the task becomes to find the best way to chop logs and now shifts to a cognitive non-routine task, the team with a person who can design a wood chipper is now going to crush the team who only knows how and has strength to chop the logs quickly. A huge number of tasks in medicine are cognitive non-routine. And so in thinking about it that way, we now see with the previous example in combination, how diversity can create a huge bonus for us. And again, this is not just cultural diversity. It definitely includes cultural diversity, gender diversity, but it also includes skill set diversity and training level diversity and even training background. So when we talk about teaming, we think a lot about interdisciplinary teams. And as a disclaimer, I'll probably say this more than once. This is not to say that there aren't those times where a physician just needs to take leadership, take ownership, and become that boss because a patient's life is in danger. And sometimes that's what we need. But many times, if we think about the diversity bonus that is the skill set, the background, the training, the specialty, then many times we can now see that there is a bonus to creating that team and creating a diverse team. Now, while the mathematics of diversity bonuses are sound, and we have an enormous number of cognitive non-routine tasks in our lives, why do diverse teams sometimes fail? And why do we see ongoing and substantial achievement gaps among sometimes women, underrepresented minority physicians, and others? Well, simply being present doesn't mean a skill set is used. So take, for example, a new hire who trained at an outside institution. And if he or she is dismissed every time he or she suggests an alternative treatment method because that's not the way we do things here, they're going to eventually stop making suggestions. And along those same lines, if you hire an engineer under the claim that you want them to find a better way to chop wood, but grade them on how many logs they can split in an hour, they're going to look like a failure because they didn't have an opportunity to demonstrate their actual skill set. You've probably all heard the old saying, you know, if you grade an elephant on its ability to climb a tree or a fish on its ability to climb a tree, it's always going to look like a failure. Thus, we have to be mindful of how we foster and evaluate diverse professional teams. And that evaluation can be that formal evaluation that we do in academic medicine, but it can also be the way we think about our teammates and those who are helping us. If our expectation is always that of what we view as success or what we view as the proper outcome. Again, in patient care, sometimes that is very clear, but other times we need to rethink our evaluation in the way that we see the success of the team, because that diverse input can really move things forward in the long run. So diversity is being invited to the party, but that can still sometimes fail. Inclusion is being asked to dance. We need both. And so finally, how do you operationalize this? Explicit, transparent criteria is key. We have deep-seated biases to things like us or people like us. So when we're hiring or building a team or recruiting new residents or forming a team of interprofessional individuals in the hospital, we need to be really upfront about the skills that we're missing. We need to self-evaluate and think about the skills that may be needed. And also, sometimes we can't see those ourselves, so sometimes looking for an outside source to objectively evaluate is helpful too. And we need to make those criteria very transparent and explicit, and we need to make our evaluations match. So I have a few case examples. If you all are able to speak up, it would be wonderful. If not, I'll kind of pause for a minute. And I would love if anyone has specific examples of maybe something similar that's affected your patients. Please throw that story out here. I would like for us to have some discussion. This format makes it a little difficult, so we'll do our best. When we think about teaming and on-the-fly groups and how they might be improved or have been improved by diversity and inclusion in the past, I think these cases provide just a foundation, but you guys probably have very, very memorable examples from your own patient care, own teaming experiences. So this first one, the hospital forms a cancer support group that meets at a location not readily accessible by public transportation. How might this differentially impact the patients? So I saw this happen. I trained at OSU in Tulsa, and it wasn't exactly this situation, not specifically, but I saw the population of patients who had no transportation. Here in our rural program, transportation is even different because there's no public transportation whatsoever, whether they can afford it or not. And often our patients live an hour away from the clinic. So although they have some resources through the Choctaw Nation, we think sometimes we're helping by providing these services. And because our lives are not impacted by that specific scenario, we forget to think about those details that might actually make a service essentially non-existent still to the patient. So when we think about teaming, how could these organizers have avoided this misstep? Well, I think the obvious answer is to ask those patients. There's so many times when the answer is ask, or ask diverse members of the hospital, because when you have social workers and other members of the care team, we're thinking about the medicine and how the support group is going to help them with that and help them deal with their side effects and their issues they may have, when other members of the care team might bring about an entirely new viewpoint and allow us to think about things that we don't at all. What do you do if your provider or organizer population differs substantially from your patient population? So at this point, I'm going to pause for just a minute and ask you all to think about a time when you might have seen something like this happen. And I'll leave just a moment of silence if anyone has a specific example. I feel like we see this so frequently with the disparities here. And again, these cases aren't meant to point exactly back to that teaming experience, but rather a time that doing a better job of teaming could have really impacted the patient care. Does anyone have any examples that you've seen?
Dr. Clayborn, this is Doug Nolan. We did have we had a committee that was supposed to represent the patients. This is several years back, to help with how the system performed. The issue was that they used employees that were also patients. So realistically, what you got is you got the employees' feedback and not necessarily a true view from most of the patients.
Yeah, that is a perfect example. And we've seen very similar things here. And you think about the bias that exists just within that patient population. If they're employees, they make it to work on a regular basis, which means they have transportation, they have resources that many, many of our patients don't have. Thank you for that, Dr. Nolan. It just confirms what we're saying here. Okay, so I have a couple more of these cases, and then we're actually going to shift gears a little bit. So in creating a departmental family leave policy, only women faculty members are asked for their input. I'm a mother of 4, and so, you know, it just makes sense when you first read it, and then it's like, no, it doesn't make sense at all. This is 2021. Families are built of multiple family members that don't always look the way that my family looks. And so how can we approach this in such a way that it's not a single answer from a single group of people that look alike, think alike? Whether you agree with certain things or not doesn't negate the fact that there are families that are different. There are going to be, we have many fathers in our residency program. Some of them have stay-at-home wives, some of them have working wives. My husband is a stay-at-home dad, so our situation is very different than that situation where both parents are working. We went through that even just a couple weeks ago. The ice storm happened. A colleague, her children were out of school, and she had nobody at home to take care of them because they're both, she and her spouse are both physicians. whereas I was able to just show up because I've got somebody at home to take care of mine. So even amongst that situation, we're both mothers, but our family situations are very different. So I think this one is quite obvious, that it's just really important when you think about this from a teaming angle. You're just talking about a group that they were asking questions, but creating a policy that's going to affect everyone, and very different individuals potentially. So asking what seems to be the obvious group, well, we'll talk to the moms. Well, that's wonderful. We should definitely talk to the moms, but moms are not the only family members. And so I think this one's quite obvious. I'll give just a few seconds if anyone wants to speak up or has anything that's personally affected them and that you'd like to add to that. And so we'll move on. An elderly patient tells the attending that he doesn't want the guy with the rainbow pen rounding on him in the morning because he knows what that means. I am so sad to say that I've seen things very similar to this in this hospital and others, but and not just this topic, but it's been said in such a way that, you know, I don't want the person with that accent. I'm not sure where they're from. And it's been multiple different accents. It hasn't just been one culture that the patient doesn't like, but for varying reasons, our patients have shown racism. And again, it's not specifically one race. They've had their reasons, and not that I agree with that, but they've had their reasons, and I've seen this, and it breaks my heart that it happens. And so it's something that I think we should talk about. So what can we do when our patients display these behaviors? And does that change if we're an attending versus a resident? Just something to think about. Potentially it does. Does the fact that this patient is older change how you would respond to him? In my mind, it may. Should it? No, probably not. But when I think about that and just my honest gut instinct, does my bias affect how I'm handling this with a patient? And what happens if the patient becomes verbally abusive? I think, again, there's some pretty obvious answers here, and we should just shut this down. And I think most of us would. But I just bring this about because, again, we're pushing diversity here, and we just talked about the importance of diversity, cultural diversity, skill set diversity. And so now with that knowledge, I hope that we're equipped to explain that to our patients. So if nothing else, this case can point out, you probably knew that diversity was good for your team, but now you're equipped with the ability to say, here's why. And if that's not good enough, then shut it down. I think that that's the next obvious point, is that our job is to be there for our team members, and not to, most of them are able to defend themselves, but we shouldn't tolerate behavior like that from our patients. It is abuse. Okay, and I think this is the last case here, and then we'll move on. The hospital has formed a culture committee, but has only invited department heads, most of whom are older white men, to participate. Nothing wrong with older white men, just like earlier, nothing wrong with asking mothers about something that's very familiar to them. But in thinking about this, as Dr. Nolan said, when you have a congruent group, your input is going to differ greatly. So what can we do about that? And how do we better learn the needs of our communities and our patients, especially those that we aren't a part of? You know, I don't know what it's like to not have transportation. So how can I learn from those patients? We can sit here and talk about diversity all day, but I grew up in southeastern Oklahoma. So how am I fully going to understand the culture of an individual or a group of individuals that I don't come from? And again, that obvious answer is we ask. And I think we hear that a lot around our program too. There's so many things that we realize that as a rural culture, we don't know. And so getting a better understanding, and I've learned this from physician groups on social media, The right answer sometimes is just to say, I don't have that answer. Let me ask. It's not offensive to ask. So in this case, in teaming, ask those members of those cultures to participate and help us learn how we can better provide for potentially employees, patients, other members of the team. So if you'd like to dive into that a little deeper, here are some examples of further reading. We won't stick on this slide, but it's there if you'd like it. I really enjoyed kind of learning about this. But as I said, for the reasons of we spend a lot of time recruiting residents and trying to put together the best team for our program here. So it directly applied to what I was doing a few months ago, but it also directly applies to your care team each and every day. Okay, so we're going to shift gears a little bit now. We're going to now talk about teaming as it relates to team leadership and what we as physicians can do. So I don't know if you all have seen this movie, but I felt like this was so true. Every workplace has this crew. You got the one that, you know, I think as physicians, we often see ourselves as the guy on the left. He does 99% of the work. He knows what he's doing. Just get out of his way. We've got the guy who has no idea what's going on the whole time. We've got the guy who says he's going to help, but he never does. And then you've got the one that disappears at the very beginning and doesn't show up again until the end. And, you know, as we know, it probably even takes credit for it sometimes. Sound familiar? Probably so. And so what really is a physician-led team? Well, now we're going to kind of talk about the care team more than we're going to talk about the academic team, but I want you to think about it from both perspectives. I liked this definition. A physician-led team, as we think about it in terms of patient care, is a multi-specialty, multi-professional member group working collectively in a blameless way under the leadership of a physician whose knowledge and expertise, together with leadership skills, can achieve measurable goals. There is evidence that this improves outcomes, improves patient safety, and improves satisfaction. So is it still important that we as physicians lead those teams? My opinion and what the evidence says is absolutely. So when we talk about these things, and I automatically bristle a little bit and think, well, I'm the physician, I'm going to be the leader. And I really struggle with giving up that control. And I think many of our personalities lend that way. So again, we talked about diversity and why it's sometimes important to include others and include other skill sets. But in shifting gears a little bit, now we're talking about how we can do that and still maintain leadership. So I think often the outside world sees doctors in this way. They're just, you know, screaming orders. They're writing them maybe, but they're just barking orders. And so leadership is seen differently. And sometimes we may provide that leadership in such a way that maybe, unfortunately, this is true. I think often not. I think sometimes it's just interpreted that way. Here's another example. So different world, but it's just, you know, the doctor's saying what to do. Of course, I threw in a female here. I think one of the biases against females, if you're a female listening in, I think so many of you would agree. In medicine, we often feel that, or sometimes have experienced that a male physician can give the same order and it's seen as, you know, leadership. And a female gives that order and now all of a sudden it's bossy, or there's another word for that, but I won't say it in this professional setting. So you see here, she's got her hand on her hip and, you know, the man is providing leadership. The female sometimes, well, no, you're bossy and you're not treating me well. And so is that always true? No. Am I trying to throw in this, we should feel sorry for women? No, but I do think that many of us females in medicine have felt that. And so want to say it because I know it's obvious to you all. So is that how it should look? No, that's very obvious. We all know that. And we don't feel that we're leading in this way. But again, sometimes it's interpreted that way. And so thank you, Google, for this, you know, perfectly scripted and practiced picture of what the team could look like and should look like. But really, in my mind, when I think of an interdisciplinary team, in my mind, the leadership I provide looks like this, and it feels this way, and it should feel this way, even though this is, a completely fake picture. And so basically, how can we set that up? Many sources these days, and even some things I've learned through faculty development, will tell us sometimes that we should dismantle the hierarchy. That scares me. In many settings, and I even think to something that, my kids unfortunately eat more McDonald's than they should. McDonald's still has a manager. They still have a hierarchy because those aspects of leadership are important. And so it doesn't mean that the manager necessarily thinks they're better, but their role is different and necessary. So the idea of completely dismantling the hierarchy to me is not the best. And I think that we should carefully avoid that, but do it in such a way that we maintain leadership and respect by not just stepping all over people and taking advantage. You've probably heard, with great power comes great responsibility, and it's our responsibility to use that power carefully and maintain it in such a way that our patients benefit and the team is involved. So therefore we have that diversity bonus, but we've included other members of the team, but we've done it in such a way that it's not seen as those previous pictures show. So I don't know about you guys, but my med school looked more like this than a leadership course. I wasn't writing papers on how to be a good leader. I was learning things like this. So how can we make that culture shift? Well, I think through conversations like this sometimes, through talking a little bit more about leadership, as much as, sometimes, as I said, putting this together, I was like, I'd rather read Inborn Errors of Metabolism, but sometimes we need to talk about leadership. So we'll make this part quick. Boss versus leader, you can read it yourself, but just to quickly throw these out there, just the general meaning. A boss is somebody who gives orders and behaves in an authoritative way, seeks control, and tells his men and women what to do. That's a boss. A leader influences, inspires, supports, encourages that group of individuals and works continuously on the achievement of goals. Now, this applies across medicine, other industries. So, and I think it's so obvious sometimes, but I still think we sometimes forget that approach. Again, disclaimer, there are times in medicine that a boss is needed to save a patient's life. We shouldn't discount those times. But in the times that we can, because we understand diversity bonus in a team now, we should strive for leadership. Leaders have followers, bosses have employees. Leaders gain respect due to their ability and the quality of their character. Bosses, again, the power, they just have respect due to seniority. Leaders are people-oriented, bosses are profit-oriented. Leaders innovate and collaborate, whereas bosses administer and dominate. Leaders show commitment, bosses show control. Leaders drive the team with values, and bosses drive it with standards. And I can't help but say, how many of you all see these things? And I think about physician leadership that is also focused on patient care. And then I think too sometimes, and there are outstanding non-physician leaders out there too, but I think about those scenarios where as physicians, we've worked maybe under a leader that isn't a physician. And I can see these circumstances where, yep, it's based on standards. It's based on what they told us to do, not what is best for our patient. I know you all have felt that. Leaders focus on vision, bosses focus on structure. Leaders show how the work is done, bosses know how the work is done. Leaders show authority and delegate the authority, bosses just delegate tasks and responsibilities. Leaders prefer to teach, bosses like to tell. And when there are mistakes, leaders fix it and help point out what's wrong, bosses place blame and show who is wrong. I think hopefully, even though that's obvious and simple, reading through it makes you think about those times where you as a physician have fallen under a good leader, maybe an attending or, within a team that works that way. And those times where unfortunately that hasn't happened, or you think about the times and maybe this, allows you to think about future employment and where you might want to work and what that system may look like. I hope that it does that for you too. Again, there are non-physician leaders that have the right goals in mind, and there are those that don't. So in thinking about this, hopefully you can either think about becoming that or in seeking that for your future place of work. So we'll run through this quickly. It's just an example. You're the primary physician managing a patient in a hospital with an interdisciplinary team, including other specialists, nurses, pharmacists, and therapists. Although you've taken the lead, one of your collaborators from another specialty or discipline keeps making changes and disagrees with some of your management, refusing to stick with it. So this was my instinct. I'm rolling along and I'm this normal pufferfish here. I think that they're cute. And my instinct is no, just no, I don't want to deal with it. I'm right. This is what's best for the patient. I'm going to order it, and that's it. That's the end of the story. And I think a lot of times, unfortunately, that is our physician instinct. Again, times when that's appropriate, but in the times when it's not, how can we deal with it in such a way that relationships are maintained, and not only maintained, but maybe there is something we don't see sometimes. And so instinct is there's nothing I don't see, follow my order. This is what's best for my patient. But I'm going to quickly go through an approach that will sometimes maybe help foster those discussions and open our eyes to things that we haven't seen. And that is through conflict resolution strategy called I statements. We're not here to just discuss all of conflict resolution today, but this is one brief strategy in having discussions with other team members that might actually help. And in reading through this the first time, I gave a talk on conflict resolution with the faculty last year, and it actually did help me in dealing with, I realized that I did these things from the beginning, but kind of putting them together into a formal technique helped me outside of the medical world too. So if nothing else, this is just a communication technique, but within our interprofessional teams, and sometimes even not interprofessional teams, just with colleagues, this can help you just communicate better. So the I statements, I see, I think, I wonder. The I see, I think, I wonder model of feedback can be used to share your frustration. So it still allows you to vent, but it allows you to constructively inquire about the nature of the problem. So we'll start with going back to the previous example. I see is kind of our camera check. What data did you see or not see? And it gives your colleague a chance to share something you may have missed. So on that example, sorry, it's overly generalized and honestly quite comical, but I noticed that you changed the fluid orders. So this is just that statement of fact. I see this. I think. So discuss your perspective in a direct but respectful way. Respectful. Focusing on the work, not the person. So it is okay to say, I'm frustrated because I thought we agreed when we last discussed the plan of care. I'm concerned the rate you suggested may cause fluid overload and more respiratory difficulty. Overly simple clinical example, but I think this makes us both think, okay, I don't think I missed anything here. Why did you crank up the fluid? Well, I think we know where this is going. It's the other specialty may be suggesting that the patient was dry, the kidneys need perfused, and so here we go with that. Next is I wonder. Do your best to turn your frustration into curiosity in order to learn more about the other person's perspective. So I wonder what your thoughts are on this. I'm hopeful we can discuss balancing renal perfusion with the patient's other comorbidities. Yet again, there are times in medicine, it doesn't need to discuss the patient is in danger, we need to fix it. But there are times, and I think it's so important to remember that medicine is constantly evolving. This is an overly simple example, but medicine is constantly evolving, and I learn things probably every day, and often from people I didn't expect them to learn from because I communicated and had an open mind about that. And so lastly, kind of putting that all together, the shift from what the to what's their frame. So WTF now means what's their frame. That's tough in our minds. I want to be that puffer fish. I'm right. Follow my order. Leave me alone. You're taking up my time. But through curiosity and a patient first mentality, we can leverage accountability so we can still hold people accountable. We can let them know our frustration, but in an environment that gives us the safety to learn and improve together. So once I know where a team member is coming from, I can then move forward. How do we do that? In this case, something came out that really makes it make a little more sense. It still, the outcome is probably the same, but we schedule a brief team meeting to review the patient's progress because clearly we're not on the same page. We're surprised to hear that that member described above had previously received feedback, maybe as in the first year of training, and received feedback that they weren't taking enough initiative in managing cases independently. Maybe that decision was not fully correct, maybe not, but that person had received that feedback and so was doing their absolute best to, I'm going to take initiative, I'm going to put it in order, I'm going to make a decision. I know that that has happened here, and we've given the feedback as faculty, hey, work on this, make a decision. And then someone turns around and says, don't do that, my goodness. And so this situation was real to me, even though it was overly simple. By avoiding false assumptions and exploring the true nature of the problem, we were able to resolve the conflict and move forward to patient care. So I think this also points out the conflict isn't just what should the fluid rate be. The conflict is the feedback that this person had received and was trying to grow as a physician. And then because we maybe didn't fully communicate in the first place, that could have been missed in both sides of the team. All members of the team would not have learned as much from the case, and the patient's care ultimately may have suffered. So in summary, you guys may or may not agree. I wasn't like a big Tom Brady fan, but I did enjoy watching the Super Bowl this year. I enjoyed watching the success. When we think about teaming, we think about that scenario that's not a team that's practiced together forever, but is teaming on the fly, is forming a team with a diverse skill set on the fly so that we have the most success. Is success winning the Super Bowl? In his case, yeah. And I think about the scenario with Tom Brady where the success seemed to follow him. And whether you like him or not, that seems that it may be true. And so as physicians, I want to think about us in that way. As physician leaders, I would hope that the success can follow us. And just as, some people said about Brady and the Buccaneers this year, he helped build that team. He knew the pieces that it needed for success. So when he went over, he put together a team and led a team in such a way that led to a Super Bowl win. I think what we do, whether, the world sees it or not, is actually much more important. Taking care of patients, saving lives, preventing chronic conditions, whatever your specialty allows you to do, is definitely more important than winning the Super Bowl. So I hope that learning to build that diverse team and what its bonuses may be in skill set or in culture, and then learning some leadership skills will be helpful to you in the future. This one was for me. If a diamond cutter is asked to report every 15 minutes how many stones he has cut, by distracting him, his boss is subtracting value. So that was a final statement for myself too. I find myself not wanting to let go, and this statement stood out to me. Here are some sources. And so at this point, if you all have any questions or further discussion, I'll welcome that.
Well, Dr. Clayborn, thank you so much for that provoking and enlightening presentation on teaming. And certainly it gives us an opportunity to think about how we team and how we lead with our fellow team members as we see our patients in the outpatient and inpatient environment. So thank you so much. We enjoyed your presentation, and we hope you would come back and join us again.
Thank you for having me.
Thank you, Dr. Clayborn.